When we choose a treatment plan, once again, it's very dependent upon where your disease is, what kind of symptoms you're having, and what your energy level is. If there's any potential for any type of intervention to be completed, your case will be discussed at a conference in which we have pathologists usually there, radiologists there, radiation oncologists there, surgeons, and many of my other colleagues. And if the case appears to be something that is a potential for any type of intervention other than just chemotherapy alone, we will gladly discuss your case there and make the most appropriate decision for you. And unfortunately, for a patient with metastatic disease, sometimes we have to go through this process repeatedly depending upon what treatment regimen you're on, whether it be first line or third line, etc. I like to ask my patients, what do you like to do as a hobby? Do you have young children? Do you like to do fine handwork? Are you kind of very active, outdoorsy? Maybe sometimes then, the PICC line, which is an external line, is not ideal for the patient. Whereas a portacath, which is underneath the skin, is something that allows the patient a little bit more, he's not so limited in regards to what he needs to do. However, that has its own limitations as well, because then you have to have, basically, we don't like our patients to touch the ports themselves in regards to chemotherapy administration. Once the chemotherapy has been completed, we like them to come back into the hospital, which is a second trip, and sometimes that's inconvenient for the patient. But also they have to understand that if that port gets infected, obviously they're at risk for getting a severe, basically a bloodborne infection, bacteremia. So those kind of points of discussion are very, very important. Not only choice of chemotherapy, but the type of administration of chemotherapy, the various schedules of chemotherapy. There's got to be a lot of discussion going on. And especially if you're in an academic center where basically your infusion suites are open maybe Monday through Sunday, 7 days a week, whereas in the community practice setting, they're only open Monday through Friday. So then for most of us, for colorectal cancer, we have 46-hour infusions for chemotherapy, and then that means that that individual is only able to come in for chemo basically Monday, Tuesday, Wednesday, because then he has to get disconnected on Friday. So it's not convenient for him to go to necessarily a community center if he's hoping to have chemotherapy on Thursday, Friday, or even Saturday, Sunday. So those kind of things do have to be taken into account, as well as the fact that some patients will suffer from fatigue. Obviously, once the chemotherapy has been administered, then you have to take into account basically how it impacts your job, how it impacts your social life. We have a lot of patients that enjoy, once again, being outside and socializing with friends. We want them, obviously, to maintain a very normal lifestyle as much as possible. I think at the end of the day, it makes them a better patient and they tolerate their chemotherapy better. But you really have to go through all those various points to learn about the patient and whether or not they have a social support system. Obviously, an individual living on their own, especially if they're elderly, it is at a disadvantage, unfortunately. We have to be very, very careful with those patients in regards to toxicities of therapy. Treatments that we provide, if you are unable to go under surgical resection, the point of the treatment is really to get control over the disease. So currently, your disease is not in control at this time, and so we need to establish control over the disease. And in this setting, our primary goal would be really to at least have whatever is there shrinks, and and we don't want any new disease to form. So in that setting, that's definitely a possibility. The tumor will regress at some point, but down the line, at some point, it may become resistant. And that's fairly common, unfortunately, with chemotherapy and cancer. But then we have other lines of treatment that we have to provide to you. I think it's very important to keep in mind for a patient with metastatic disease that's not necessarily going to go to surgery, we need to look at this almost like a chronic illness. I don't necessarily want you to look at it just like cancer in and of itself. You need to look at it as something like rheumatoid arthritis, diabetes, lupus, something that you can live with, but you're just going to have to adjust yourself to understanding that there are going to be some highs and lows of receiving treatment. Unfortunately, that's the reality. But the good news is that the chemotherapy is quite good nowadays, that your survival can be quite extensive, and we have lots of other options available.